Okay, so it is my great pleasure to introduce to you Dr. Robert Lowe. Dr. Lowe is Associate Professor of Medicine at Boston University School of Medicine, and his specialty is gastroenterology and hepatology in particular. And he and I were actually classmates in medical school, just celebrating our 25th reunion last night. So, true pleasure to introduce Dr. Lowe.
Thank you very much, Andrew. And it's a great pleasure to be invited to sort of give a talk on a topic that I spend a lot of time thinking about and talking about to people. As an educator, I think the idea of teaching clinical reasoning is something that is a little bit frightening to people and a little bit difficult. Because very often our trainees will see an experienced clinician reason through a case, and it will seem to them like magic. That they can't figure out how this process occurred. And so I think it's important for us to think about this and think about ways to teach it. And I hope during this talk to give you a few frameworks about how to do things, and then we can have a little discussion at the end about questions people have. I do like to start out, however, with a quotation by George Bernard Shaw, where he said, "Few people think more than 2 or 3 times a year. I have made an international reputation for myself by thinking once or twice a week." And I think this is not to sort of, belittle us, because all we do as physicians is think. We think about cases, about what we're doing, where we're going, but it's very rare that we step back and say, how did we do this? How did we come to it? It almost seems like an osmotic process. And really, that's very hard for our trainees to understand. So I want to give us a few frameworks on how to approach this. But the best way to start anything like this is with a case. And this is a case about me. And I entitled it My VA Experience because this actually occurred here at the West Roxbury VA, where I had worked in the past, but I was invited to give a clinical problem-solving conference. And for those who have seen these or been part of them, there are a couple of ways these things go. In some cases, the speaker is given a case little by little up on the screen, and they're asked to talk through it in real time. And in other cases, they're actually given a protocol. They're given the case maybe 2 or 3 weeks in advance, and they get to chew on it and pour over it, and then come in and discuss it. And that was this kind of case. Some trainees had handed me a case, given me 2 weeks to look it over, and I realized when I came into the room to discuss it, I had no idea what was going on, which is not common, because usually if you spend a little time sorting through things, you have a sense. And so I'm going to take you through the case as I saw it, and show you how this relates to the way we teach clinical reasoning. So here it is. It was a 53-year-old woman who presented with 18 hours of fairly acute onset of vomiting and some chest and abdominal pain. Her past medical history had a few things going for it. She had some irritable bowel syndrome that was well controlled, dysfunctional uterine bleeding, also not an active issue at the time, some allergic rhinitis, hyperlipidemia, and a diagnosis of ADHD, but her only meds were atorvastatin and methylphenidate, and they had not been changed at all in the last few years. Because it was one of these cases that's being presented to an outside person, there were a few tantalizing hints with some prior travel to Mexico, Brazil, and she lived in the southern U.S. for a while. She was an avid gardener, and I know all of us in internal medicine immediately have to say sporotrichosis under our breath. This is not a case of sporotrichosis. It never is, but we always have to think about it. She drank alcohol socially and really did not appear to be an excessive alcohol drinker. She had a 20-pack year smoking history and no history of IV drug use. The protocol went on to say that her physical exam was remarkable really only for a bradycardia with a heart rate of 36, normal blood pressure, and some minimal right upper quadrant tenderness. The remainder of the very extensive physical exam on the protocol was completely normal. They continued to give me more information with a normal set of labs, a full set of labs, a normal chest x-ray, a right upper quadrant ultrasound, which would be something I could ask for, which was normal, and an EKG with the photo of the EKG on the protocol that showed only sinus bradycardia. So now I'm sweating a little bit as I read this, as I'm trying to think through what this could possibly be. But they continue on. She was admitted, had some intravenous fluids, got 1 dose of atropine early on for this bradycardia, but was never symptomatic with it. She had ondansetron for her nausea. And overnight, the only thing that was remarkable was when she was having a bowel movement, she had a brief syncope for about 5 seconds, and she had a short sinus pause on her EKG. So, of course, the next morning, she had an echocardiogram that was negative, a stress test, interestingly, that was negative. This was given to me beforehand, and a chest CT also, for whatever reason, which was negative. And here I am coming into the room with all this information, and I realize that I do not have a clue as to exactly what's going on. So let's break for a second and think about what I was doing in my head as I walked into this room. And so for those who are not familiar with this book, Thinking Fast and Slow, it's actually quite excellent. It's a very long book, a little difficult to get through, but Daniel Kahneman, along with Amos Tversky, won a Nobel Prize for decision theory way back in the late 70s, early 80s, and he's been writing about this and experimenting on it for years. And this book lays out really a sense of how we think about any sort of situation, including clinical reasoning. And I think the key part of this is his 2 systems of thinking. and he named them, not very excitingly, System 1 and System 2. And so System 1 is our pattern generation system. It's fast and automatic. We see something, we recognize it. It is intuitive, and it has actually a bit of an emotional content to it when you make that decision. But it really is what we use to recognize patterns, and this is how we live our lives. We don't constantly think very deeply about everything around us. You contrast that with System 2. That's the slow, effortful system. When we're not sure what's going on, we start to deliberate and think logically and work through a problem. We also use that, but we try to live as much as we can in System 1. Not only is it easier for us, but it's also energy efficient. The brain uses less energy when it can make these rapid decisions that are encoded into memory. Now, clinically, this makes sense to us, right? So here's a picture of someone's buttocks with a rash on it, and I think most physicians would look at this and say, oh, this is zoster. That's a System 1 approach, right? We recognized it, we knew what it was. I had one trainee say, well, could it be poison ivy? And I said, well, he says, what if he's running naked through the woods? I'm like, okay, I'll give it to you. But in general, this looks like herpes zoster. Now, here's a rash, a little bit different. And although someone might look at it and say, oh, it looks like a purpuric rash, maybe this is a vasculitis, now we've got to think. What could be causing this? Is this drug-induced? Is it a ANCA-associated vasculitis? Is it lupus? And we would start to really think very hard and ask a lot of questions. And that's a System 2 process. And so System 1, we use that all the time. That's how we make our rapid diagnoses. And it's based on patterns that we've encoded into memory. And I'll discuss that a little more as a key element in how people develop their diagnostic reasoning skills. And so, in this case, someone with a fairly acute nausea and vomiting, the things that run through your mind are viral infections, food poisoning, obstruction, maybe biliary colic and cholecystitis now that it's going on for several hours, even perhaps an inferior MI that can behave this way. But as you can see, all the things that I thought about were nixed by the protocol. We had everything from a radiocarbon ultrasound to an EKG. We had no signs of obstruction on exam, so it was very difficult. Now I will say, nausea, bradycardia, and someone who had lived in Brazil does make one think of some interesting things, and a pattern that occurs there is Chagas disease, and since it was a protocol that I was being brought in for, I entertained it for a moment, but it really didn't really fit the pattern. So here I was, trying to work with System 2. So now we need a deliberate reasoning process. And this actually helps us clinically. We use it in a couple of situations. We use it when there's no pattern. We make a lot of diagnoses off the cuff pretty easily, but when we don't see a pattern, we really start to sort of hunker down and think about it. However, it's also useful when it prevents us from jumping to conclusions, right? And that line there, keeps us from jumping to conclusions, could be the beginning of a 3-day symposium on diagnostic error. We're not going to go there right now, because there are a lot of things written about diagnostic error, but we're talking now about our trainees. They need to get a sense of how to do this before we tell them about the pitfalls and errors. So we'll sort of step back away from that. And so for this case, here I was, nausea, vomiting, bradycardia. So I thought about, could there be vagal stimulation going on? And why would that be? Could there be some infiltration of the nerves, gastric tumor, amyloidosis? Could there be a toxin? And so as I was sitting there, as they were running through the protocol, I was in my head ready to put on what I really considered in my mind a dog and pony show about how I was going to get to a possible diagnosis. And then something happened. So this is a schematic of the protocol that I received. And you'll see that little box at the bottom there, and that was the EKG, and that's how big it was. And all I could make out was sinus bradycardia. But then as they're going through the protocol, they put up on the screen the actual EKG for all to see. And as I'm sitting there sort of bemoaning my fate, I look up at this and I realize I know what's going on. And it relates to this as one representative trace, which I could not see on the small version of this EKG. Now, having trained at a hospital where the chief of cardiology was Eugene Brunwald, we were taught, even though I didn't become a cardiologist, to read EKGs with some alacrity. And so this made me say, aha. And I show this picture of Sherlock Holmes, not to give myself credit, but really because when you give a talk on clinical reasoning, you are obligated to show a picture of Sherlock Holmes. And so, I've discharged my duty.
How many people today in your audience do know who Sherlock Holmes is?
I
think that's the crucial thing, actually.
I will say this, I think most know, but actually when I gave this talk in China, in Shanghai, I showed a picture of Benedict Cumberbatch as Sherlock Holmes because I heard that they all watched that and they all recognized the picture. So here I'm using the older version. So, why did I say aha? Because now my System 1 came to the rescue. I saw a pattern. This looks like digitalis toxicity. Why? Nausea, vomiting, abdominal discomfort, bradycardia with block, and that EKG finding? The only thing that I was missing in my little script was maybe some visual changes. She had no visual changes, no halos around the lights or anything. So System 1 gave this to me. But the question is, what do you mean digitalis toxicity? She only takes atorvastatin and methylphenidate. But you remember, she was an avid gardener. And sure as shooting, she had gone to her garden and cut up plants and leaves to make a salad for herself, and it was the foxglove in her garden that was the key. And so sitting in the room, I broke into sort of a calm sweat, having realized that now I could talk about this case intelligently, because up to this point I would be grasping at straws. And so this really reminded me, and in fact I stood up afterwards and talked about this. At that time I wasn't aware of the System 1, System 2 dichotomy, but I talked about my own fears in discussing this case. But I think it really shows you how the patterns are what we should really work at. So, how was I taught as a medical student to do diagnostic reasoning? It was this painstaking process to collect all the data, do the history, do the exam, write down the labs, write down the imaging, and then look it all over and generate ideas as to what was happening. Huge lists of ideas. And then I could collect more information and finally come up with an idea. But that's not how we do it as clinicians, right? We do it like this. The minute we start collecting data, we generate ideas as to what is happening, and we make this iterative process. And it's based on these patterns that we were aware of. And so as we're doing this process, we ask ourselves a few questions. Do I see a pattern? Is something starting to come out? And if it does all the data fit this pattern? So we may generate a few different diagnoses, ask a few questions, and if something starts to rise to the surface, we can get there. But one of the mistakes that we all make early on is we don't wait for all the data, right? We make an early decision, what's called in the literature premature closure, which many of us have heard of. And I'll give you one fantastic example about this. I was sitting in Morning Report and a case was being presented, and it was wonderful. A gentleman was walking to the bus stop to go to work, and he fell down. And he said, I was paralyzed. I could not move my legs. I just couldn't move them. He was very scared, but it only lasted for about 2 minutes. After about 2 minutes, he was able to get up again, and since the bus stop was near a hospital, he walked right into the emergency room. And by the time he got to the emergency room, he was complaining of a little bit of epigastric mid-chest discomfort. And that was presented to a group of trainees. And they immediately started to develop a differential diagnosis. Is this GERD? Is it pancreatitis? Is it an ulcer? Is it a heart attack? And I'm sitting in the back sort of vibrating a little bit, and finally I blurted out, which of these things knocks you down in the street paralyzed? And they all looked at me and I was like, you're ignoring the obvious. That was a key thing. And so I said, I think this is a dissection. And I think he temporarily knocked off some of his spinal arteries. And that's what it was. But the idea is you've got to account for everything going on. I think one of our former training directors, David Battinelli, he said, he used the idea of the barking duck. He said, if you see something and it has feathers like a duck and webbed feet like a duck and a beak like a duck, it might be a duck. But if it opens its beak and it barks, it's not a duck. Because you have to go further and figure out what's going on. And that's the important part about using System 2 to back up System 1, just to make sure everything's there. And have I ruled out all the alternatives, right? That's the issue of premature closure. But I'll tell you, our medical students, they are begging for premature closure. They have no closure, right? So we have to get them to the point where they can even start to think about their diagnostic errors. So how do we do this? And again, as I point out, System 1 and 2. So everyone wants this. Everyone wants a clinical reasoning process by which we're able to sort of make diagnoses no matter what the situation. Something like this, where we'll sort of look at the stuff, put it together, and have a diagnosis. But unfortunately, that's not how it goes. And so, some principles from the cognitive science literature about how this works. In one, and it's the most daunting one for people, is that clinical reasoning requires a background level of knowledge. Even though we have all the world's knowledge on our phones, you have to have some that's in your head that allows you to start to generate pattern recognition. So biomedical data and clinical data is important. And I think the best way I've heard it written is this way: infinite access does not equal infinite knowledge. Right? And so the real question is, well, how much? We've all been inundated with material in medical school. What is the amount of clinical and biochemical knowledge and biomedical knowledge you need? Well, we have to go to the medical school. And so Mark Twain said, I never let my schooling interfere with my education. And so we've got to think about how to reform education, and that's not what this talk is about. But if you think about your medical school, you might get this picture. Here we are, the tower. That light is the dean's office there. They're there working on the budget. And there's always a group of students and faculty who are interested in reforming the curriculum, and they're usually sort of very calm and collected. Here they come now. And they're heading to the tower, right? And when they get to the tower, what is the first thing they want to jettison from the tower? It's always the same thing. It's the Krebs cycle. The poor Krebs cycle. Krebs cycle's never done anything to anyone. It's a perfectly reasonable cycle, but it's just a marker, and it's mentioned in the literature over and over again, and everyone says, why do we have to learn the Krebs cycle? Yes. So of course no one should need to memorize the Krebs cycle, but understanding metabolism is important, and so we need to figure out what the key amount of information is. We don't know yet, because we're not doing a very good job of figuring out that amount. But as you see our trainees, one thing they can't say is, oh, I don't have to know stuff, I just have to know where to find it. That's not true. They actually have to have a knowledge base in their head that's built up over time and experience that is used to generate these diagnoses. So unfortunately, there is no clinical reasoning process independent of biomedical knowledge. And we know this is true from the literature. We know these things. Students have a great difficulty recalling basic factual knowledge. They can do it for a few weeks to take an exam, and then it gradually weans away. This is a great time of the year. Our third-year students have all taken the boards. They were second years just a few minutes ago. They have the most knowledge of anybody in the hospital right now. And gradually, by about December or so, they'll be back down to baseline. And I've always wanted to develop a cerebral emptying scan that would allow me to see how this knowledge is actually removed from their heads. But you can't recall it just as an entity. But once you see a patient, once you tie that knowledge to a clinical entity, you will remember. And everyone remembers that they remembered CHF drugs for a test, but once they took care of a patient with bad heart failure who was not doing well on the beta blocker and no one had put them on an ACE, suddenly they know how to treat heart failure. It's based on clinical experience. And so one of the things we're not doing well enough in medical school is giving people enough clinical experience early on, rather than filling them full of facts. And so why is knowledge so important for being a good clinical reasoner? First of all, it's a mnemonic device. When you're learning clinical features, you can hang it on pathophys. And when we talk about the evolution of a clinical reasoner, you'll see how important that is early on, using pathophysiologic knowledge to guide you before you have clinical experience. Number two, we use this information, right, when we don't have a pattern. I just showed you that. I was thinking of nausea and vomiting. Normally I don't think about the vagus nerve or about infiltration, but here I was, not knowing what was going on. So I thought about what was anatomically there, what could physiologically be going on, what biochemistry, amyloid deposition, toxins. These were running through my head, and that's based on my clinical experience with a set of biomedical knowledge. I had to have it. I couldn't just look up what is causing this woman's vomiting. I had to be parsimonious about it. And when you look at experts and you look at clinical reasoning studies of experts, they use this but not explicitly. They've already done something called encapsulation, and I'll come back to that to give you a sense of what it means. And the concept of an illness script is what we're going to talk about in the next few minutes to give you a sense of how we, as experienced clinicians, put our knowledge together, which is something we can tell our trainees. But first I want to define one term, problem representation. This is throughout the cognitive science and clinical reasoning literature, and what it means is an abstract representation of the patient's case. All of us have sat through a presentation where the student says, Mr. Jones was sitting at dinner having some steak and he developed some discomfort in his chest. He said there was a pressure-like sensation. He managed to finish the steak, then he went to the bathroom. It continued. He felt it in his shoulders. Well, then he laid down on the couch for a while. His wife said, what's wrong? You can go on for quite a while. That needs to be abstracted into acute onset of chest pain. That's how we make our diagnostic criteria, right? We need to turn a story into a few simple facts. And so this abstract representation depends on a few things. One, and again, to use some of the jargon in the literature, it depends on semantic qualifiers, which is a very interesting sounding term, but what it means is opposing features that allow us to make diagnoses. And a few examples, acute versus chronic, right? Chest pain right now versus chest pain going on for 3 months are entirely different things. If someone has a painful swollen knee, is it just monoarticular or polyarticular? A whole set of diagnostic categories appear. For a rash, is it macular or vesicular? Again, that allows us to start the process. So it can't just be a red, itchy rash. It needs to be a vesicular rash, and that allows someone to start doing this. And being able to represent a problem like this in the literature, and I mentioned George Bordage there, and I do have a list of references attached to the slide set. He's one of the fathers of this process in terms of thinking about how we use these things. What we've shown is that this allows you to compare and contrast various diagnoses. It allows you to start building your differential in your head that will serve you for the rest of your career. And we know from the literature, this, by giving you the knowledge of the defining parts of illnesses and what discriminates different ones apart, activates memories you have of cases and allows you to make diagnostic reasoning. And so, how do you assess someone's problem representation? By that summary sentence at the end. The synthesis is what we call it here in Boston. People use different terms for it, but at the very end, when someone says, so, in summary, this 52-year-old man presented with acute onset of chest pain radiating to his shoulder. That's the one-sentence summary. And so the one thing I can implore people to do is to not focus on elements of the presentation that are your pet peeves. It doesn't matter if the chief complaint is a one-word, chest pain, or a quotations, my chest hurts, or this 52-year-old man presented with chest pain. And all of us have, perhaps ourselves, or have seen someone harp on students and trainees about these semantic issues. I like the past medical history in reverse alphabetical order. Oh, I like it in forward chronological order. And we spend so much time on that that when we get to the end, everyone goes, oh, we don't have any time for this. It's pneumonia. The key is this summary. The key is the synthesis, not the way you like things in order. So we need to concentrate less on that part and about our ability for the students to abstract out the synthesis, because this is how we teach them to reason. And so here was my illness script for digitalis toxicity. Patients present usually with nausea and vomiting, abdominal discomfort, bradycardia, maybe block, the characteristic EKG findings, and then plus minus some blue halos around the lights. I had this in my head, so when I started to hear about these things, I would have thought of it earlier if the patient was on digitalis, or if I could have seen that EKG. This is what we do. And that's how I would summarize this case. Not her ADHD, not that she lived in the southern U.S. That's my summary. And this together is what gets called an illness script in the literature. And I think this is probably the most important concept here, is that we all, as practicing clinicians, have illness scripts in our heads. And what is an illness script? It's the stored memory of a clinical case with all the attendant things around it. All the cases we've seen of this entity, the things we've read about it. It all comes together to a single nugget in your memory. And that's what we use to base our diagnoses on. And so what do we know about it? It is a problem representation, right? That's why it's so important to have them summarize the case. So when they hear acute onset of chest pain in a smoker radiating to the arm, their acute coronary syndrome script should start to get activated. Unless something else is going on. If there's blood pressure differences in both those, maybe their dissection script will start to be activated. And this is how they can start to work through a case. And it's what we all do. But it's hard to explain unless you're really thinking hard about it. And here in the literature, when you look at expert clinicians, an illness script really consists of three basic parts. There's predisposing factors. 55-year-old man, smoker with a family history of heart disease, hyperlipidemia. That's a good set of factors. Clinical features. Chest pain, maybe radiating down the arm, a pressure sensation, nausea, vomiting, diaphoresis. And then, in fact, when you actually look at expert clinicians, they have a little bit of pathophys there as a nugget. They usually don't immediately say, oh, I think there is a clot on an atherosclerotic plaque. They say, I think this is an acute coronary syndrome. But they know what that is, and that helps them when things aren't quite right. And so again, I mentioned the basic script for the ACS, but we have the predisposing factors, the clinical features, and then the pathophys. And we all have this encapsulated, and that's the word we use to put these things into a little capsule that's in our memory. And so when you work without a script, here's how medical students do it, right? If a patient has chest pain, diaphoresis, and shortness of breath, we've told them to make extensive lists. List everything that can cause chest pain, everything that causes sweating, and everything that causes shortness of breath. And they say, I'll list them all and try to find the common elements from all these lists. And the next thing that usually happens is this question. Because we can't stand to listen to this, right? It drives everybody wild. And it's not a good way of thinking about reasoning, making exhaustive lists. It's really trying to work through what scripts are being activated. So we need to avoid this process. And so, what do scripts do for us? They let us focus the history and physical, right? When someone says, I'm short of breath, and you start to say, well, I have a pneumonia script, a PE script, a COPD script, you start to ask questions. Are you a smoker? Never smoked. All right, my COPD is coming down a little bit. What have you just been doing? I've been on a plane from China. My PE starts to come up a little bit. This is what we do, and that allows us to ask questions and then focus our exam. Nothing's worse than when you say, what's the exam? Well, there are no hair changes, no eyelash changes, no eye changes, no nose changes. Obviously, if you're focusing on one place, it allows us to do that, which is what we all do as experienced clinicians. And we need to get our students there bit by bit. But here's a key point. It depends on your experience with clinical conditions, not on how old you are, not your year of training. And I'd always say that if you have a fourth-year sub-intern who just spent a month on rheumatology and saw 10 cases of gout, and you have a junior resident who's never haven't seen a case of gout, and someone comes in with gout, the fourth-year student's going to do a better job of recognizing that. Doesn't mean they're a genius. Doesn't mean the resident is stupid. It means that experience plus reading is what builds your illness scripts. And so, we need to have learners see as many patients as possible. That's the way we do things here. All of us have built our scripts over time because of that. Our ability to see patients and work through cases. Reading is clearly important, but it's got to be tied to what we see clinically, so we can build those scripts. So I look at this. If this blue screen is all the MIs that ever happened in the history of mankind, our student can identify this group, right? There's an elephant sitting on my chest. It goes down my left arm. I have a sense of impending doom. I'm very sweaty and nauseous, and I smoke. I do everything. Anyone can pick that one out. Our residents have a little bit of a broader set of scripts. They know it doesn't have to go down the arm. They know that the impending doom thing is kind of interesting, but not there, right? But then our internists who've seen even more understand that it can be nothing in a diabetic. It can be a little bit of a nauseous sensation, a slight pain in the jaw. And our cardiologists, I'll tell you, they can recognize MIs where I, as a medicine attending, will say, I really don't think so. Like, I've seen this before. I know she's 20 years old and she says it feels like there's a bird on her shoulder. but that's an MI, and sure enough, they're right, because they built up these scripts. But now we have the blue screen as the entire world of medicine. And these are the cardiologist's best scripts. MIs, aortic stenosis, wide complex tachycardia, CHF, pulmonary hypertension. They got these really big scripts. They can pick it out of a lineup. But over in the bottom corner, that's the GI scripts. That's where I live. Our cardiologist has very small scripts for GI. If they saw a 20-year-old with bloody diarrhea for 3 months, they could probably say, I think it might be inflammatory bowel disease. But they won't pick out the nuanced cases. Whereas me, as a gastroenterologist, here's my set of scripts. They're pretty big. Crohn's disease, ulcerative colitis, celiac, GERD, colon cancer, and my cardiology scripts may not be as big as that. So again, the biomedical knowledge is key. And a really good diagnostician in one field may not be as good as another, because it's not the reasoning process alone. It's based on what you've seen and where you've been. But it's not just a set of scripts. It's the interactions between the scripts. So now when I hear the word diarrhea, I activate a few different scripts. My GERD script doesn't activate, but my ulcerative colitis, Crohn's disease, celiac, they do. Similarly, I have to think about the way scripts interact. Crohn's disease and celiac actually often interact in terms of oral ulcers, sometimes weight loss and malabsorptive stuff. Ulcerative colitis and Crohn's disease clearly have similar features. So I've got to be able to sort of look at those. And then I have to think about cause and effect. If you have ulcerative colitis, colon cancer is much more common. So now I've built connections between these scripts. And this creates that rich network of diagnoses that an experienced clinician can do. And so by telling our students this, that this is how it has to build, from step one all the way to this, they understand that it's a process, that our best student is not a great diagnostician because they haven't had the experience or the chance to put these things together. But now, how do we develop this skill? And there's some great data, and one of the references I'll give you, and I'll show you the reference in a second, talks about this process developing. So let's take it from the novice to the expert. The novice. The novice likes to relate symptoms to pathophysiology. That's all they've got. They don't have clinical experience. They've learned a lot of facts. And so for them, if we said, oh, there's a patient coming in infected and there's bacteria in their bloodstream, they will go back to the books, right? They'll say, all right, so gram-negative bacteria might have lipopolysaccharide release, and I remember that lipid A is the active moiety, and that induces neutrophil migration to the site, and cytokine release, and vasodilation, and so the cytokines will cause fever, vasodilation causes low blood pressure. They're starting to put this together, but it's all pathophys, and it's painstaking. Our intermediates recognize these symptom complexes and now encapsulate all that basic science knowledge into a clinically relevant term. And so when they hear fever, hypotension, and bacterial infection, they think sepsis. And if I ask them, what do you mean by sepsis? They say, well, bacterial products or lipopolysaccharide can induce vasodilation and neutrophil, but they don't say it out loud, and they're not even thinking it out loud in their mind. It's underneath. The word sepsis now has a capsule in their mind, which the novice student doesn't have. Then comes the expert, who further encapsulate these clinical presentations into illness scripts, right? And so sepsis plus right upper quadrant pain and jaundice is cholangitis. That's an illness script. Sepsis plus cough, sputum, or right lower tick could be pneumococcal pneumonia script. But that's not something our novice can do. They've heard of pneumococcal pneumonia, but they can't put all this together because they need a chance to encapsulate this information into clinical terms and then see patients that then activate memories. And that's the whole illness script concept. And it really is very effective in building clinical reasoning skills. So, for strategies to do this as an educator, I refer you to this article by Judith Bowen in New England Journal of Medicine 2006, probably the best summary, even though it's more than 10 years old, of how a person can sort of teach this process. It's an excellent article. But I want to review some of the strategies. So number one, maximize the number of patient experiences. Right? And it doesn't have to be the complete workup of the patient. If someone's on your team as a third year and you know they're only supposed to have 2 patients on the service, make sure they are listening when everyone discusses the other patients. Make sure they're an active member of the discussion. Make sure they see people on rounds, see findings. Don't limit them to that, because the more they see, the more they will begin to build these illness scripts. And so that case of polyarticular gout, which always gets everybody the first time they see it, because they assume gout's a monoarticular disease, once they've seen it, it'll be on their list next time. So they'll know to aspirate for crystals. They'll put it on the list along with other polyarticular disorders. We need to have them see as many patients as possible. Outpatient, inpatient, it doesn't matter what. And I'm hoping that as medical education moves forward, many schools have started to have more clinical experiences in the first 2 years that help them tie all that basic pathophysiologic knowledge to a clinical scenario. Next, help them create this one-sentence summary. That's the focus of the presentation, right? You should be able to see that they can gather information, but it's how they put it together, not how they structure it, not how they do it in the order you like, not that it's done according to some King's English or rules you're looking for. Make sure you spend your time on the end of the presentation, the assessment part. How did they put this together? Could they use semantic qualifiers? Could they distinguish the fact that this is more chronic chest pain? So acute MI shouldn't be on your list. It's been going on for 3 months, right? This is a monoarticular disease. You really should be thinking about sepsis and crystal-induced arthropathy as your major, and Lyme disease as your major factors, not rheumatoid arthritis. That's what we should be doing with them. And so if we can help them get to that point, that will really improve their clinical reasoning skills. And it's a place that we often miss out because we move right to the diagnosis and then talk about therapies. Because we spend so much time on the first part of the presentation, we're getting nervous, we want to move ahead. It's an odd traditional element of medical practice, but we need to sort of move in a different direction. Think about how we're thinking about our cases. And then you, as an educator, need to think out loud. You need to demonstrate your scripts. Right? That's the great thing about clinical problem-solving cases, is that the person stands up and goes, here's what I was thinking when I heard the first part, and then I added in the exam. And then I added in the labs and the EKG, and now I have an answer for you. Nothing is worse than an attending physician walking in, looking at a chest x-ray and saying, start clindamycin, and walking out. And everyone goes, what do you mean? Whereas, in fact, the issue is, oh, yes, this is an alcoholic who was found down, may have vomited. That right lower lobe infiltrate is where aspirations go. And because I'm worried about aspiration, I'm worried about anaerobic coverage, so please include clindamycin. So much can be done with that simple sentence that you did, because you showed them your script. You showed them the predisposing factors, you showed them what was going on anatomically, and you showed them where you would go with it. It takes no time, but you can't be cryptic or oracular about your diagnoses. You need to show them, so the next time they can do it. Patient experience, teaching experience, all these things play into it. Next, make the trainees prioritize their diagnoses. For some reason, I certainly grew up in the era where the more things you put on your list, the better student you were. Throwing the rarest diagnoses on the list meant that you were very, very good. And so people would say, this patient's short of breath. Well, I guess it could be pneumonia, or lymphangiomyomatosis, or COPD exacerbation, or pulmonary alveolar proteinosis, or pneumonia, and you would just sort of go out of your mind. Make them decide, what are the top 3 things you think are going on? I'm a big fan of the top 5 idea. I tell my students, you should have 5 things, the 5 most common things for any complaint, from headache to chest pain to shortness of breath, and know the questions you should ask and the exam findings and what you expect to find in the labs. If you can do that, you'll be great, because most people have the top 5 things. And after you've diagnosed a few of those, then you'll come to one that doesn't fit. And then you can learn the next 2, and the next 3, and the next 2, and soon you have 30, 40 things. You have to build them that way. You have to start with priorities. You can't see tuberous sclerosis around every corner. And this compare and contrast strategy is what I like to use. So when I tell students, I'm like, I want to know why you think this patient is short of breath. Tell me what made you think PE, what makes you not think it? What makes you think CHF, what makes you not think it? And going through that process allows them to think about that next patient who says, I can't breathe. All right, let me ask about orthopney and P&D. Those are my CHF questions. Let me ask about immobilization and recent surgery. Those are my PE questions. And that's where this comes from. And we need to do it explicitly, not implicitly. And please realize that the year of training is not the marker of competence. It's experience with patients. So whatever we've given them, it's not that they're not bright. It's that they don't know, and that we have to show them. And that's done by seeing patients and talking them through the people. You know, one of our best educators, Joel Kaslowitz, who I think recently received an award here for his great teaching, said that the only way to learn medicine is to see patients and talk with smart people on the wards. That's it. That was his one-sentence summary of the whole thing, and I think he's absolutely right. And so, when you're doing cases, this is an interesting point that came out of the recent article. It's interesting, when you think about students, you know, I mentioned there were 2 ways of doing cases, right? You can give it to them bit by bit, piece by piece, or you can give them the whole case to chew on. It ends up that in the cognitive studies being done, novices, early medical students, do much better when the whole case is presented to them. Because they can't keep things in mind. They don't have scripts. So they can't say, oh, shortness of breath, I'm thinking of 5 things, and as you add things on, they get very confused. But if you give them a whole case to chew on, they can say, oh, history, findings, physical exam, labs, I can start to build it up. But with residents, a morning report approach works very well. You can present the cases to them little by little, because when you say the history to them, they have 5 or 6 scripts in their mind. Then you add things to it, and they see what's on the list and what's not, and what's better and what's worse, and they can work through it. So it may be better in the earlier phases of medical training to use whole cases and let people spend some time chewing on them. I thought it was an interesting finding. It was not intuitive to me. There were several studies summarized in this review sort of pointed in that direction. So I've changed my practice a bit in terms of how I work with first and second year students versus later students and residents. And then the last point I want to make is about reading. So Will Rogers said man learns only in two ways, one by reading and one by association with smarter people, which is similar to what Dr. Castle had said. So I think if all of us thought about our medical training and thought about the number one piece of feedback we got throughout our entire training, it was two words. It was read more. The least useful bit of information you could possibly get is feedback. There's an entire universe of reading out there to do. So what does read more mean? So I'll tell you what my approach is to sort of guiding reading for students. Reading should promote diagnostic reasoning at their level, especially a third-year student on the wards, but even an intern. This is not the time to say, oh, read this great review of the molecular genetics of this disorder. It's how do I tell this patient who's short of breath whether they have a PD or CHF or COPD. So their reading should be guiding them to learn the defining and discriminating features of diseases. You know, the hot joint, what makes it septic, what makes it crystals. That's what we should be doing. And so you should be able to distinguish an MI from all the other causes of chest pain. What are the history findings, the imaging, the labs? And so molecular genetics is fantastic, but it's not going to help you with your diagnostic reasoning. And so if a student or an intern or a resident has an interest in it, they can read about it separately. But when you're going to guide them, take them to the place where they can learn these things. So my advice is, and I tell every student this, when a patient comes in with a new disease or complaint you're not really familiar with, go to UpToDate, the dreaded UpToDate that we all get worried about. The worry is stopping with UpToDate. But I say go to UpToDate and skim it on that topic. Because again, it's usually pretty long. Get a sense of what we're talking about. Then go to the literature and find a recent review about that. New England Journal has great reviews. So do several other journals, depending on what field you're in. And skim that. Don't take careful notes on it. Don't look for every detail, but get a sense of what this disease is all about, what its features are. And then I tell them, also grab one clinical trial about what a patient's, maybe it's a drug they're on or a test that's been done. If you read the introduction and the discussion of that trial, and maybe an editorial that goes with it, you have learned plenty about that disease thing and how it compares to other things. And then stop and go on to your next patient, because you have a whole life ahead of you. If you have a patient with CHF, do not go to Brunwald's textbook of heart disease and read the 80-page chapter on CHF. And it is still 80 pages back when we trained. I checked. In 8-point type. Impossible. It cannot be done. But if someone's now on the new neprilysin inhibitor, hey, have them read the Paradigm HF trial, the New England Journal. Just by reading that study, which I read as a gastroenterologist, I learned an awful lot about the latest in cardiology. And have them stop there. And then go on to that next patient with gout. And that's how we should do it. And so, read more doesn't help, but go and read this, this, and this, and then move on. At least helps focus them a bit. And I think, again, if we're thinking about making these folks diagnosticians, which should be our goal for our early learners, right? They're not going to know the nuances of treatment. That also takes time and experience. But to make them diagnosticians, I think that's important. And I'll stop there. We can take some time for questions, but I hope this gives you a bit of a framework and maybe encourage you to read some of the literature. I included some papers in the little reference guide here that are readable, good summaries, and actually sort of take a lot of information and put them together. I find it a fascinating topic. And again, you can also read the literature on diagnostic error, which goes back through some of this as well. But I'm happy to take some questions right now.
Okay, well, thank you very much for that fabulous presentation. I'm just going to start by mentioning one thing that I think I've learned from the presentation and am going to apply in my own teaching. When I am in my busy clinic with lots of residents and other trainees, sometimes there is 2 residents waiting for me to staff the cases or even more, and they don't always travel all with me to see the patient. But now I'm going to make sure anybody who is available to come and learn at the bedside or at the clinic room will now come with me, so they'll see more patients. So that's great. Okay, now I'm going to unmute your line so that you can ask questions of Dr. Lowe. But please, you yourself, mute your line if you're not asking a question. Thank you. Okay, do we have a question on the advanced line for Dr. Lowe?
Thanks.
And remember, if you're not asking a question, please do mute your line. Question on the line for Dr. Lowe?
Point where I think it's important to continue to monitor A1 blood sugars, but I was thinking of making no changes.
Yes.
Given that we have
Okay, we're going to do some questions in the room.
blood sugars.
So this relates to your point, Andrew, because the people on the line, I do exclusively inpatient medicine, and one of the struggles I have is this idea of more patient exposure, more patient sort of cases to have as to add to your illness scripts, and particularly for the intern whose patient we're discussing. Whose patient we're not discussing, intern number 2. So what kind of techniques have you used to try to get buy-in from that second intern to pay attention or to join on rounds when we're going to see that patient, knowing that they're overburdened at times and may not be fully invested in that other intern's patient?
Sure. That's actually very difficult, as we all know. And in fact, it may almost be an insurmountable problem in some ways, given that intern is thinking about everything they're doing at the moment. The person I concentrate more on are the students in that setting, because their problem is not so much that they're thinking about other things. It's easy to get bored when it's not your patient, right? And so I advise them very specifically. I say, listen, have a piece of paper with you, or if they're an iPad person, have it out, and jot down a few notes about these other patients you listen to. And I say, please, I'm not going to ask you to present them de novo, but jot down a medicine you haven't heard of, a disease state, a question you might have, and it keeps them in the game. I also give them the impetus that, and if the attending then turns to you and asks you a question, you're at least, your head is in the game. Because it is easy to get derailed by what you're thinking about otherwise. So I do think that jotting a few notes down about what's going on keeps you fresh and keeps you in there, and then even gives you a passel of questions that you can either ask later or look up. I asked the same thing of the intern, but I must admit, in our system, we've gone to the point where the intern who has the case is there with the team, and the other one is off doing some work to move things along. And so they don't benefit from the dual set. But I think that we can at least get the other team members to benefit from everyone. When things are quiet and the census is low, often I try to have everybody around together. But unfortunately, when things get very difficult, that's harder. But I find I can work more towards the students' attention span than the interns. But it's a very difficult problem given the way we move, the rapidity with which we can move these days.
Okay, we had another question in the room.
I don't have a question as much as I wanted to express my admiration for your lecture and share my experience. I'm teaching mostly in the outpatient setting, barring 2 months or 6 weeks that I spent in the medical consultant on the wards. I teach ambulatory medicine to 2nd, 3rd, and 4th year medical students, and this is what I do daily, virtually, having them explore patients as much as they can. They virtually see they start with 1 and end up seeing 5 or 6 patients by themselves during clinical sessions. That being said, I came into a bunch of obstacles by getting their feedback on the patients they just seen and summarizing this in 1 sentence, or I usually tell them that we have 5 minutes to present the case. I have a 5-minute rule. So unfortunately, the students mostly coming from Harvard Medical School were trained in their previous rotations that they need to rattle off the latest studies, which I absolutely do not need to hear when they present. And when you're speaking about referring them to up-to-date, I have a personal problem with it. I think the textbook, no one cancels textbooks, and maybe they don't need to read 80 pages of Roundwald, but getting basic piece of knowledge from Cecil and Robinson, and then building up on this with something they read in up-to-date, and maybe a clinical trial is my script to their, do not read more, but read in this sequence. I also think that,
So sure, I think that obviously when you have access to, say, Harrison's, and again, I am a huge fan, but again, I grew up in an era where I loved reading textbooks. Now, if you are, again, at the level of a 2nd or 3rd year student, say 3rd year on the wards, Up to Date has that sort of basic level. And so, but Harrison's might also. I think in some ways Up to Date is easier to read for certain topics, and Harrison's is better for others. There are certain parts of Harrison's I think are fantastic, others less so. But I think you're absolutely right. If you give them a specific goal, you say, go here, and look at this. And again, it would be 3 pages in Harrison's, not 80 pages in Braunwald. Absolutely, that's a good reading assignment, followed by a clinical trial. The idea is to give them something to do, not to say go read, but you're right. So whether it's Harrison's or Cecil's or Up to Date as their starting point, followed by something in the really actual literature, a review article or a clinical trial, I think that's absolutely fine. Choose your thing, but please, I'm glad you're explicit with the students as to where they should go. That's important.
Okay, we have another question from the link, and the question is it fair to assume that the processes from the cognitive science literature reviewed apply to nursing as well? I recognize that our model is different, but many principles would seem to apply.
So yes, the answer is an absolute yes. So in fact, again, the biases of the physician is that the literature that I've seen is what physicians have done, but physicians and nurses have worked together on this literature, and it's been done at all levels. And then outside of the, quote, medical sciences in terms of psychology, other places, social work, the ability to sort of make a, quote, diagnosis, whatever that is in your field, actually depends on this same process. But there's definitely been a lot of research in nursing that has the same results. The approach to seeing more folks and thinking about how you develop that illness script, because again, nurses make diagnoses just as physicians and physician assistants and all of us do. So yes, to that question.
And another question from the link is something I think actually that is an issue that comes up more and more as clinicians are all so busy in trying to see so many patients. So what do you do if an attending in a very busy practice, let's say it's an outpatient clinic, the attending doesn't seem to be taking the time to give their thinking. It's sort of like the start clindamycin approach. What should trainees do? What should junior faculty do to help getting the more senior person to explain their thinking?
Sure. I think it's really it's beholden to us as the faculty to do this, because a student, first of all, there are certain barriers to sort of stopping a clinician in their tracks, and number two, once that clinician has said pneumonia or said clindamycin, everybody stops. So it really is for us as faculty to say, what am I actually thinking at this moment? So again, it didn't take very long to say, oh, this is a right lower lobe pneumonia and someone I think was vomiting and aspirated. I'm worried about anaerobes. So we have to get into the habit of thinking about it. So it's developing a habit of mind. It doesn't add very much to a busy clinic to take that moment. And if it's not that busy, to ask the question. What do you think is going on? Give them a few minutes to think about it, so at least they're trying to activate a script, then correct them on that one element, and then move on. And I think those who've heard about the 1-minute preceptor technique, which I think was actually presented in this sort of form at one time, know that you don't have to give a 10-minute lecture on a topic. You don't have to feel obligated to give them the world's information about diabetes or hypertension. 1 point per person, per patient, is actually excellent. And over time, you build up more and more. I think we all get into the habit of thinking that this is it. This is my only opportunity to give all the world's information to this student at this moment. No. Use your moments wisely, and that frees you up. You'll feel less guilty, but you'll be teaching all the same.
Great. I'm going to try to unmute the lines again. And again, if you are not asking a question, please do mute your own personal line. Do we have a question from the Vance for Dr. Lowe?
We don't drive it.
Okay. One going once, going twice. Question from the Vance before we have more questions from the room. Okay, another question from the room.
My name is Laura Snowstreet. I'm a physician assistant, and I teach medical students and PA students, and usually other professions as well. And one of the things I do for my general orientation in how to make the most of their clinical experience is don't study for the boards. And I usually get this funny look from the students that says, what do you mean don't study for the boards? It's like, well, you're here in the medical center, you're here in your outpatient setting, you're here to see patients. So even if there's some, quote, downtime, there really isn't any downtime because you have a whole host of providers and patients that you can see whether they're on your service or not. A good example is that I walked into the surgical residence room to orient my PA students, and there were about 3 medical students sitting there, and I said, what are you all doing, for the afternoon? They said, well, there are no cases. And so I brought them all into the operating room, and I said, well, there may not be general surgery cases, but there certainly are other cases going on. So you really have to kind of open their eyes to those opportunities, like you said, and kind of go beyond what their, kind of line of thinking in terms of I'm on the general surgery service.
Absolutely. I think what you're bringing up is what I consider a sociological problem more than an educational problem. We give people competing responsibilities, right? We tell them that you should be concentrating on your clinical work here, but The shelf exam you're taking in this rotation is worth 30% of your grade. And then we berate them if they concentrate on one thing over another. We need to solve that problem as educators. But within the system, I think you're right that, and not even considering it as a punishment. Oh, there are no cases. Oh, there are some great cases. Wait, go and see this one. When you say it like that, who can argue with it, right? The idea is that if we can create that enthusiasm for the clinical scene, that's what's going to get them going. I've got to say, recently one of my colleagues who's an infectious disease specialist had a patient with HIV who came in and had classic skin findings and mucosal findings of secondary syphilis. And he walked into a room of residents who were typing away and said, "You've got to come see this." And they're like, "We really can't, we're just too busy." And he was completely dejected. And I would have been also. But I said, you should have grabbed them by the scruff of the neck and brought them out of the room and made them go see it. Because once they got in the room, they would get excited again. You have to get past the activation energy of all the things we put in their way. Shelf exams, typing, notes, all those things, you have to really pull them away, and you can't expect them to self-motivate. Once you get them in that room, people do light up. That's one thing you notice. We've got to get them in there to see the patients.
So the question sort of geared towards, again, the more senior faculty or even junior faculty, not the learners themselves. How do you, as an individual, sort of practice this? How do you increase the number of illustrators that you have even now? It sounds like you recently read the Paradigm AF trial. I don't know that there are many gastroenterologists offices who do that. But are there things that you have routinely that you do to sort of continue to hone your skills?
Right. And so I don't, well, personally, the reason that I do this is that I attend in general medicine as well, and I enjoy working with the third-year students and residents, and so it allows me to keep my skills up. That's a personal interest. Many of my GI colleagues are not interested in those sorts of things, but they do keep up within their field. So even if you are concentrating on one specific branch of medicine, I think that keeping up in that case is really, it's really the best way to keep up is to have students with you, isn't it? When you have trainees with you, it reminds you of the basics. It reminds you of what comes next and allows you to really constantly hone your ability to talk about cases and think about them. Personally, I do make it a habit to sort of try to finger through the other literature and pull out things that are of some, newness or interest. Do I read everything about everything? Certainly not. But it does, the idea that I attend in general medicine is what keeps me on my toes. I know I'm going to need to know a number of things about the basics of the new anticoagulants, which would not really apply to me very well. And so that's what I do. All of us know that we used to have stacks of journals that we didn't read. Now we just have an ether that we haven't read. So it's much easier. It's much easier on the environment, but it's the same. And so you've got to pick and choose based on where you're at. But don't feel you have to know everything about everything. It really is finding the things that you are going to become that expert at, and then imparting that expertise to others. That's the fun of being an educator, but it also is where they will get that ability to sort of put things together. So I don't have a good, glib answer for that. But I try my best to sort of, be as much of a polymath as possible.
Just to share the experience that I have, it's the discussion, not just the questions. I found that they frequently can quote the latest studies, but once you, especially on the words, you try to go a little bit deeper in the understanding of certain things, you realize that it's non-existent. I usually do with every team of the words, introduction to stress testing and variable clearance, and as a simple question of why do we use 85% of maximal heart rate as a limit for treadmill? And the best answer was because Cardiac Fellow said so. But they all can say this, that it's 85%, but none, virtually, not anyone can explain why. And I think this is a fairly standard situation with many other things. So we train them to practice evidence-based medicine, and I hear from my younger colleagues, oh, you're so old school every single day, but in reality, not every evidence-based medicine should cancel out the understanding or clinical script or whatever that is called clinical expertise.
I just had thank you. One other question, and I think this goes trans-professional in terms of how these skills are used, and that is when the educational mission kind of clashes with a clinical legal mission of let's say the team is sending out lots of consults to find out answers to things, but doesn't incorporate kind of a thinking atmosphere within the team, and so in mental health, let's say I'll get a number of consults for a behavioral issue, or my area of serious mental illness, it's somebody who just went to a nursing home, first time in a hospital, and now hearing and seeing things. So, and there's a quick, sometimes impulse to send a consult rather than to flush through. And I'm wondering just how you tease that apart on your team. Of where's the learning cross into clinical consults, other legal things?
Oh, sure. I mean, the legalistic issue, I mean, in many cases the consult may be gotten eventually, but I think that as long as someone sort of makes that effort, and like I say, I want my earliest trainees to have 3 to 5 things in mind. So I'm like, all right, this person's confused and delirious. Give me a few things. And so they give you a few, and then we say, all right, let's add a couple more in. And over time, you'll do that. If at some point, and again, if an experienced, that's going to again be the faculty, right? If an experienced clinician says, oh, here's someone who's never had psychotic features, first time in the hospital is doing this, I may not want to call anybody. We're going to sort of try to do our sundowning protocol and see what's going on before I go wild. At the same time, making sure they're not hyponatremic, right? That's our job. For them, they're going to sort of put their feelers out, and you have to let them and give them a chance to do that. But you're right, if they say, let me just call psych or call neuro, we're like, let's take a moment. I may still have to do that at the end of the day. But, and again, those things don't take that long. We just get so bogged down that we're very quick to go 1, 2, 3, 4, 5, let me go up. But if you took a beat and said 1 add, 2 add, 3 add, it really doesn't add very much. It's a mindset. And it's constantly being beat out of us a little bit by the system. And we have to constantly step back and take just a few moments. And it's those moments that people get a little bit of info. I think people's fear is that once I start teaching about this, I'm going to need to give a 5 to 10 minute talk on the topic. That's the issue. And if you can give people the permission not to do that, like really just one clinical point, just one. Just do that. And they add up throughout the day. That's probably the biggest problem, is our fear that we're not teaching enough, when in fact we are.
Okay, well, I want to thank Dr. Lowe for his wonderful presentation today, and we will see you again next month. Dr. Kopor?
We actually have a small break for the summer, the first